purposes, welcome to another video at the Tooth Factory. Today we're going to continue the Dental Pharmacology lecture with a new edition of NSAIDs and Acetaminophen, Analgesics Part 1. This is for the AFK INBDE edition, created by Dr. Kannan Shah and presented by Dr. Rishi Shah. In today's lecture, we're going to talk about the analgesic classification overall, then pharmacology of NSAIDs, therapeutic actions of NSAIDs, then adverse effects of NSAIDs, contraindications of NSAIDs, then drug interactions of NSAIDs. Remember, this video has already been made elaboratively for all the drug interactions, so please check that out. And then we're going to talk about aspirin, its toxicity, and then ending with acetaminophen for today's lecture. The next lecture will be on opioids, which is the Analgesics Part 2, so please stay in touch, and here we go. The classification of non-steroidal anti-inflammatory drugs. There are 6 groups of NSAIDs. Acetylsalicylic acid, ASA for short. This is where aspirin falls in, and it's one of the most important NSAIDs we're going to talk about today. Propionic acid derivatives, and that is ibuprofen, flumbuprofen, naproxen sodium, and ketoprofen. Remember, naproxen and naproxen sodium is very, very useful when it comes to cardiovascular disease patients and their painkillers. Then COX-2 blockers. We'll talk a lot more about the the cyclooxygenase to be precise later on, but COX-2 blockers have celecoxib and rofecoxib. We're going to then talk about oxycams, which is piroxicam and meloxicam. And then acetic acid derivatives, which is diclofenac sodium, etodolac, cilindac, indomethacin, and ketorolac. Now these we don't really touch upon, but they're there in the classification. The alkanoic acid derivatives, which is nabumetone. So we're going to mainly focus on this group over here for today in details. So first of all, the NSAID's arachidonic acid cascade. What does all that mean? Well, we need to first understand the physiology of our body and then where the NSAIDs act. So first of all, our body has arachidonic acid being produced, right? Upon stimulation or upon on its own. So arachidonic acid gives rise to lipoxygenase and cyclooxygenase. This is COX. Cyclooxygenase will lead to COX-1 and COX-2. COX-1 will further divide into prostaglandins and thromboxanes. COX-2 will have its own prostaglandins. So now remember, we're looking at 2 different types of molecules, prostaglandins and thromboxanes. In COX-1, the prostaglandins are used towards gastric protection, so the mucosal protection of the gastric tract, the uterine contractions during menstruation or pregnancy, and then renal maintenance, which is proper functioning of the kidneys. This is done by PGE2, which is prostaglandin E2. This is very important, so please remember this point. And then thromboxanes. Thromboxanes have to do with the blood, right? It's got platelet aggregation activity. Whenever thromboxanes are present, there's platelet aggregation. Therefore, the THXA2, thromboxane A2, creates clots. So very important here. When COX-2 is active, the prostaglandins within it cause pain, inflammation, and maintain renal function. There's also another entity known as prostaglandin I2 or prostacyclin. Prostacyclin. I'll write that down. It's very important. Prostacyclin. This is for dissolving clots. Remember, our body not only creates clots, but it also dissolves them, right? In order to maintain equilibrium. You want to maintain equilibrium. You don't want the body to create too much clot. You don't want the body to keep dissolving the clots, right? You need it to maintain an equilibrium. Therefore, our arachidonic acids and cyclooxygenase will lead to COX-1 and COX-2 imbalance. Another fun fact is that when tissue injury occurs, COX-2 is being activated, which then leads to pain, inflammation, renal function maintenance, and prostacyclin introduction. So, where do we think the NSAIDs act? Well, they act here, and they act here. See, remember this. The cyclooxygenase 1 and 2, COX-1 and 2, are blocked by NSAIDs. Therefore, all of these functions are blocked. Then there is lipoxygenase, which then gives rise to leukotrienes. Leukotrienes are responsible for causing bronchospasms and inflammations. Now, why is bronchospasm written in red? Well, think of it this way. If, for example, this cascade is activated and NSAIDs have been used to prevent, pain, inflammation, and so on, then the whole cyclooxygenase cycle is voided. So where is all the activity going to go? Well, right here. It's going to increase the lipoxygenase and leukotriene activity, leading to bronchospasms. Therefore, NSAIDs shall not be used when there is hyperbronchospasm, such as asthma. So that's just a fun fact. We'll get back to it later and keep our brains churning here. So what are NSAIDs' therapeutic effects? NSAIDs will block COX-1 and COX-2. We know that. So now, if COX-1 is blocked, let's take a deeper look. Then there is no prostaglandin E2, there is no thromboxane A2, and therefore it will lead to no gastric protection, leads to ulcers. No uterine contractions, lead to menstruation issues. And no renal maintenance. Now, I do want to bring back this point. When it says no uterine contractions, menstruation issues, well, that is, by issues I mean natural order of action is disturbed. But we need to understand that when contractions are voided, it is a pain reduction. So when women face menstruation cramps and so on, they can take NSAIDs to reduce the cramp pains. Basically, that's what it means. Then no renal maintenance, which means the kidney function is down, and then no clots formation or impaired wound healing. This and this is the same thing. When clots are not formed properly upon injury, that leads to impaired wound healing. Again, ulcers is an example of that. All of that will happen when NSAIDs block COX-1. What about when NSAIDs block COX-2? Well, there is no prostacyclin, or PGIE2, right? PGI2, sorry. Therefore, there is no dissolving of clots, there is no pain, there is no inflammation, and there is no renal maintenance. Now, this right here is ideal. This is what we need. But no renal maintenance, which means the kidneys are affected. Now this is going to be a problem. No dissolving of clots, which means sustained thrombi. It can lead to a problem. In which sense? Well, think of it this way. If a person has, thrombus issues and it doesn't dissolve the clots, this will lead to clotted arteries. Therefore, so many CVS issues. Remember this point, we will get back to this, that COX-2 is responsible for a lot of heart problems because of a sustained thrombi due to lack of PGI2, prostacyclin. So, what are the therapeutic effects? We got anti-inflammatory effect. We learned how that works. Antiplatelet, that's ASA specifically. Aspirin is used for that purpose. Analgesic. Antipyretic. Now we haven't touched upon this, so remember we will come to this mechanism. And then antidysmenorrheal. This is the menstrual cycle pain. Menstrual cycle pain blocked, right? And pro-leukotriene effects. Now this may not be therapeutic, but it does lead to pro-leukotriene. Remember, when COX is blocked, everything will lead to lipoxygenase and cause bronchospasms. As every point in this lecture is important, so feel free to write it down, pause me whenever you need, and rewind whenever you need. So remember, we said we're going to talk about the antipyretic. Here it is, the fever cascade. The antigen, whenever there is a bacteria or a virus or a microbe that enters our system, we have the PMN cells, the neutrophils, that are activated and come to the site and increase in number. That leads to the pyrogen cytokine release. See, these PMN cells will release these pyrogen cytokine releases, such as interleukin-1, tumor necrosing factor, or interferon alpha. All of these are messengers. They will go to our brain and tell us that, oh my God, there is a fever-causing mechanism needed. Why? Well, that's when the hypothalamic and the brainstem thermoregulation center decides that let's alert the entire body that there is a microbe. Whenever there is a virus in the body, our brain, specifically the brainstem and the hypothalamic thermoregulation center, will alert the entire body that there is an intrusion in the body. This will lead to prostaglandin release, specifically COX-3 in the brain. Remember, so far we've talked about COX-1 and COX-2, right? Well, this is COX-3 in the brain. Where will this be affected? In acetaminophen. We'll talk about COX-3 in acetaminophen. When COX-3 releases lots of prostaglandins, it leads to peripheral vasoconstriction. Whenever the peripheral vasoconstriction occurs, there is an increase in body temperature that we call as fever. Now, remember that for this mechanism, we usually take antibiotics. We can stop the fever mechanism here. For this mechanism right here, we take what they call as host modulation. Here, sorry guys, I'm just going to remove, let's erase this. It's just more clear that way. Sorry about that, guys. Okay, so it is to control this part of the mechanism, we take what is called as host modulation dosage. This is specifically like doxycycline at lower doses. And then to block this right here, vasoconstricted and increase in body temperatures, we can take acetaminophen. Right here, it blocks COX-3 from causing peripheral vasoconstriction, leading to no fever. That's where acetaminophen comes in. Just a little side note for a fever cascade. Next, NSAIDs adverse effects. So what are the side effects of all NSAIDs? Such as indigestion, which is called dyspepsia, gastric mucosal damage causing ulcer, we already talked about this, peptic ulcers, gastroesophageal reflux disorder, this is in short GERD, increased tendency of bleeding, remember clotting problems, right? Thromboxane A2 is blocked, so tendency of bleeding, reduced clot formation and impaired wound healing. Renal impairment and kidney damage. Remember that all prostaglandins are meant to maintain kidneys. However, when they are blocked, there is kidney damage. And then anaphylactoid reaction. Some people may have side effects such as anaphylactoid reactions. Not anaphylaxis, but anaphylactoid. NSAIDs contraindications. When should you not be taking NSAIDs whatsoever or relatively? Well, first of all, gastric ulcers, because it'll cause ulcers, right? When you have GIT disorders, when you have bleeding disorders, renal disorders, which is, CKDs or the end-stage renal disorders, or late pregnancy. Now, this is tricky. In late pregnancy, which is the third trimester, no NSAID should be taken. But in overall pregnancy, in the first and second trimesters, aspirin should not be taken. It is contraindicated. Aspirin. Remember that point, very important. In elderly, we must learn to reduce the dose of aspirin itself. And then congestive heart failure. We should not be taking aspirin as well. See, some of these may be relative contraindications, some of them may be absolute contraindications. Now these ones in red are a little fun, so we put them on the side. First one is called the Samter's Triad, or AERD. This is aspirin or NSAID allergy clubbed with severe asthma with nasal polyps and rhinitis. When somebody has all three of these conditions, they're called the victim of Samter's Triad. This is aspirin exacerbated reactions. Next is Ray's syndrome. Ray's syndrome is very important, also asked on the exam a lot. This is when we give children that are on antiviral therapy, we give them aspirin. When aspirin is clubbed with antivirals in children, it leads to Ray's syndrome. Remember this point, very, very important, everyone. Okay, NSAIDs drug interactions. We have been through this in the video. The card for the video is right above, so please click here, guys, for the video. But just as an overview, when aspirin is taken with oral hypoglycemics such as sulfonylureas and glyburide and so on and forth, what happens? What is the consequence of interaction? Well, displacement of sulfonylureas from protein, which is the albumin binding. Hence, it increases the active hypoglycemics in the blood, increases the hypoglycemia. What does all that mean? Well, remember, just as a quick recap, that oral hypoglycemics, such as sulfonylurea specifically, they love sitting on albumin. Albumin is known as protein binding capacity, right? But sulfonylureas are inactive as long as they are bound to albumin. But NSAIDs, they love to knock these oral hypoglycemics out of albumin, and now they will be increased in activity, leading to hypoglycemia. Hope that all makes sense, guys. And if not, please leave any comments down and we'll help you clarify the doubts. Therefore, we must avoid the combination. Aspirin plus NSAIDs in clubbed with anticoagulants such as warfarin. Now remember, this has tendency of bleeding, and so does this. Therefore, there is increased risk of bleeding, and GI and oral ulcerations are spontaneous because there is no integrity in the tissue. Therefore, avoid combinations, and specifically in alcoholism. Aspirins or NSAIDs with alcohol abuse, we just talked about that, causes increased bleeding. GI and oral ulcerations are spontaneous, therefore avoid combination, stop alcohol, and lower the aspirin doses. Next is aspirin only, not all NSAIDs, aspirin with calcium channel blockers, such as, diltiazem. What happens when you club these two? It increases the antiplatelet activity of aspirin, prolonging bleeding. Therefore, we don't avoid it, but let's monitor the bleeding and bruising. It's for caution. NSAIDs overall, mixed with beta blockers, alpha blockers, and ACE inhibitors. This is the antihypertensive class. When these are clubbed, we have a decreased antihypertensive effect, causing hypertension to occur. Now, why is that? Well, remember that all of these ACE inhibitors and beta blockers and so on, they work to reduce the hypertension, right? Antihypertensive. But when the kidney is impaired due to the use of NSAIDs, then renin is produced less, leading to no ACE, leading to increased hypertension. That's how it causes hypertension rather than curing it. So let's just be cautious and decrease the NSAID duration to only 4 days when it comes to hypertension. Instead, let's use acetaminophen. Next is NSAIDs with lithium. The only problem is our kidney. See, it increases the blood levels of lithium, causing lithium toxicity because of decreased metabolism of lithium and decreased excretion of lithium. See, kidneys are impaired. Remember, kidneys are impaired. Therefore, let's avoid combination of NSAIDs with lithium. Next is NSAIDs such as naproxen mixed with alendronate. This is bisphosphonate. It leads to increased risk of gastric ulceration. Therefore, let's avoid the combination. Use acetaminophen instead if a patient is on bisphosphonates. NSAIDs overall with methotrexates, just like lithium, it causes increase in toxicity. Methotrexate is used in rheumatoid arthritis or immune suppression. It also then increases the immune suppression. Therefore, let's be cautious and decrease the dose of methotrexate. And last but not the least, NSAIDs used with selective serotonin reuptake inhibitors such as citalopram, sertraline, and paroxetine. This increases the risk of peptic ulcers. SSRIs are known to cause peptic ulcers, and so are NSAIDs. Club them together, and now we have increased the risk of peptic ulcers. So let's avoid the combination for long-term durations altogether. Okay, so let's talk about the COX-2 specific blocker concept. Remember, we were talking earlier about how COX-2 blocking it causes CVS, the cardiovascular system problems. Well, let's take a look at it in deeper concepts. Ideally, NSAIDs should be designed to block only COX-2. Well, why? Well, because it only blocks pain and inflammation if COX-2 is blocked. When COX-1 remains functional, the gastric mucosa is protected, the kidney functions are protected, and only pain and inflammation are blocked, right? Hypothetically, sounds very nice because it prevents the adversities of COX-1. Now, COX-2 blockers such as celecoxib, rofecoxib, and so on and forth were perfect, but they also block the prostacyclins, the PGI2, while leaving thromboxane A2 functioning. Remember, when COX-1 is left, the thromboxane A2 will increase. When COX-2 is blocked, the prostacyclins will be reduced. Therefore, this will cause clotting. This will cause less dissolving. Therefore, it leads to CVS problems. Hypothetically, it sounded nice. However, leaving thromboxanes functioning in COX-1 while preventing the actions of prostacyclins in COX-2 will lead to prothrombotic effects that causes clotting. Increase in susceptibility to cardiovascular diseases such as myocardial infarctions. So if you block your arteries, heart gets less blood, leads to MI, right? Therefore, there is a danger of COX-2 that led to its discontinuation. Yes, the celecoxib, the rofecoxibs were pulled off the shelves earlier last decade. Now, NSAIDs. Misoprostol and PGE analog. What is this? Misoprostols are basically prostaglandins pro-analogs. So, due to the NSAIDs increasing the tendency of bleeding and thereby causing gastric ulcers, the prostaglandin analogs was introduced to help protect the integrity of gastric mucosa, misoprostols, when you're using NSAIDs. Not on its own, while we're using NSAIDs. So misoprostol has a dosage of 200 micrograms 4 times per day, or QID, used with NSAIDs. Just a little fun fact. Let's talk about aspirin, ASA, acetylsalicylic acid, in a little bit more detail. Normally we refer to it as ASA. What's the mechanism of action? Well, we know it's irreversible COX-1 and 2 blocking action. It also decreases PGE2 because of COX-1 and thromboxane A2. It then also decreases prostacyclin due to COX-2. So when decrease in PGE2 action occurs, it reduces pain, the fever, the inflammation, reduces the protection of mucosal epithelium causing ulcers. When it decreases thromboxane A2, it reduces clotting, therefore somewhat cardioprotective at low doses. It decreases PGI2, which is prostacyclin action, that reduces the dissolution of clots. That's the mechanism of aspirin. What about therapeutic indications? We want it when you need analgesics, antipyretic, and antiplatelet. But this is important. Aspirin acts as an analgesic at high doses, antipyretic at low doses, and antiplatelet at low doses. So there are several doses of aspirin that act accordingly, and then anti-inflammatory. Anti-inflammatory has reduced PG, prostaglandin, reduced leukocyte migration to the site of injury, and then reduced plasmin, which then leads to reduced lysosomal membrane stability. This causes lack of inflammation, right? When we have increase in PG, when we have increase in leukocyte migration, increase in plasmin, and increase in lysosomal membrane activity, that's when we have inflammation. However, aspirin blocks it all. There's also another therapeutic indication of aspirin known as uricosuric effect. What is that? Well, there's low doses and high doses. At low doses, it causes gout, and at high doses, it causes anti-gout. Pretty fun, because aspirin at low doses will increase the uric acid retention in the blood. That leads to gout attack. That's what gout is, increase in uric acid in the blood. While at high doses, it will lead to anti-gout effect, because it decreases uric acid in blood at high doses. Adverse effects of aspirin. There's increased bleeding tendency. We are very, very familiar with this. It also leads to tinnitus. This is specific to aspirin, headaches, and nausea, vomiting. At normal doses, the side effects may be respiration stimulation. However, at overdoses, it can cause respiration depression. So remember, it leads to respiratory collapse later on. Peptic ulcers, when it causes PPI and misoprostol uses. Hypersensitivity reaction, this is the anaphylactoid. Anaphylactoid, not anaphylaxis, guys, anaphylactoid reaction, and has cross allergy with foods containing salicylates. During pregnancy, it has shown to cause low birth weight children, prolonging the labor, and increasing blood loss. Remember, this is increase in bleeding. This is antidysmenorrheal. And low birth is just a genetic condition that causes low birth weight if the mother has consumed NSAIDs and aspirin upon pregnancy. So remember, aspirin was not to be taken at all in pregnancy. Contraindications. Gastric ulcers, some of these we may be very familiar. It's the exact same list, right? Gastric ulcers, GI disorders, bleeding disorders, the chronic kidney disease, renal disorders. Late pregnancy is only for third trimesters for NSAIDs. And overall pregnancy, remember, in the first, second, and third, no aspirin. In elderly, remember to reduce the dose of aspirin. And in congestive heart failure, please don't use aspirin. And we have Samter's triad, which is aspirin exacerbated response. That is ASA or NSAID allergy clubbed with severe asthma in a patient that has nasal polyps and rhinitis. This is Samter's triad. And then Ray's syndrome. Remember, the most important contraindication to remember for the exam, it's children that are on antiviral therapy and clubbed with ASA. That leads to Ray's syndrome. Just a feature is exceptional fever in children. Acute ASA toxicity. These are life-threatening effects. Well, what are they? They're divided into initial symptoms and progressive symptoms. Initially, you'll lead to respiratory alkalosis, hypokalemia, hyperapnea, and tachypnea. Hyperthermia, dehydration, nausea, vomiting, tinnitus, and hematologic disturbances. Progressively, we can see coma and respiratory collapse. These are the side effects. But remember, most common that we're looking at is gastric ulcers. In chronic aspirin toxicity, also known as salicylism, also life-threatening, we can see CNS effects, prolonged bleeding, so hematological effects prolonged. GI damage and peptic ulcers, this is an example of one. This is an endoscopy. Also kidney and liver dysfunction. This is our kidney damaged by the use of NSAIDs, and these are kidney issues shown in this photograph. Last but not the least for today, we're going to talk about acetaminophen, also known commonly as TYLENOL. What's the mechanism of action? So here is COX-3 introduced. See, acetaminophen has less to do with, it's got a reduced affinity with COX-1 and COX-2. Let's just leave that to NSAIDs. But it has an increased affinity for COX-3. That is in the brain. And remember our fever cascade? COX-3 is affected in the fever cascade. So, COX-3 blocked, then we have inhibition of prostaglandins in CNS only, leading to antipyretic effect. Therefore, TYLENOL is used when it comes to fevers. It does have, however, low anti-inflammatory effects, but low effects on bleeding activity as well. However, it does still have high analgesic effects. Therefore, it is recommended to use in mild to moderate pain. And of course, we just talked about high antipyretic effects. It is ideally best used for mild to moderate pain only. When combined with codeine, we can treat severe pain. So this is just a little point to remember, that if a question on the exam states mild to moderate pain, remember it's just acetaminophen, plain TYLENOL. But when we're talking about severe pain to be treated in a patient, we can combine it with codeine, and now we can have TYLENOL T1, T2, 3, and 4. We will talk about the dosage of codeine in the further slide. TYLENOL, when combined with codeine for severe pain, leads to T1, T2, T3, T4. Well, all of them have acetaminophen at 300 milligrams, very basic. But codeine increases as we go ahead. T1 has 7.5 milligrams, generally we just say 8 milligrams. T2 has 15 milligrams, T3 30, and T4 has 60. Remember, they're roughly double, right? Just a trick to remember, you guys. They're roughly double. But what is just acetaminophen? Well, it's just TYLENOL. That is acetaminophen. Okay, guys. Metabolism of acetaminophen, this is very important. It is complete hepatic conjugation reaction. There are 3 types of reactions. It'll be shown in our general pharmacology videos in the future. So, glucuronidation at 40 to 70%, that's the method of hepatic metabolism. Sulfation is for 20 to 40%. And then CYP, cytochrome P450 acetylation at 10 to 16%. That is how it is metabolized. And yes, it is important to remember these 3 points. They can be asked on the exam. This point is very important, that when acetaminophen is metabolized in the liver, it leaves a very reactive metabolite. We call it N-acetyl P-benzoquinone-imine. This is just a general knowledge question for acetaminophen. Remember, liver. Liver leads to hepatotoxicity, right? Anything that is overused can lead to toxicity. So, the most common cause of drug-induced acute liver failure is hepatotoxicity caused by acetaminophen. See, when in large doses, which is about 10 to 15 grams, 90% of the patients will have hepatotoxicity in the first 15 hours. But in overdoses, which is double that, 20 to 25 grams, 90% of the patients will have 4 hours window for fatal liver damage, liver death. With alcoholics, or with liver disease, or clubbed together, even normal doses can be toxic to the liver. So, in that sense, acetaminophen is very heavy on the liver. Therefore, for drug interactions, when acetaminophen is taken in concurrence of alcohol, rifampin, barbiturates, carbamazepine, phenytoin, it will lead to hepatotoxicity. Now, not in all senses, but always above large doses or overdoses. Complicated interaction with alcohol. This slide is very important. We need to focus when the question asks, is the person non-alcoholic and is consuming alcohol? Or is the person alcoholic and is excessively consuming alcohol? Because acetaminophen, when mixed with ethanol in a non-alcoholic, it's okay. It's all right to take them together or have them in concurrence. But whenever the person is an alcoholic and is consuming alcohol, this can be dangerous. So reduce the maximum dose of acetaminophen to 4 grams per day. Now, I want to draw your attention to 4 grams per day because the large doses are 10 to 15 grams. That's double. And overdoses are almost 5 to 6 times. Treatment of toxicity of acetaminophen. Basically, reversal agent of acetaminophen. This is known as NAC or mucomist. This has N-acetylcysteine. N-acetylcysteine. That is used as a 750 milligram tablet. And it's a reversal agent of acetaminophen. That's all for today, you guys. NSAIDs and acetaminophen. Analgesic Part 1 taken from our references below in the description box. You can access them and ask us any questions for this lecture in the comments below or on our social media. So please like, share, and subscribe. Thank you for watching and stay tuned for more lectures coming up.